The second type of anemia is megaloblastic anemia. In megaloblastic anemia, you are going to see some megastuffs, basically cells that are going to be larger than their normal size. So where exactly is megaloblastic anemia in this classification, pathophysiological classification? Earlier in the video, we saw a type of anemia where there was decrease in production of red blood cell or defect in production of red blood cell or impaired production of red blood cell due to defect in cytoplasm. Within cytoplasm, you have hemoglobin, which contains heme part and globin part. There was defect in the heme part due to lack of iron, causing what type of anemia? Iron deficiency anemia. But now, instead of cytoplasmic defect, we are going to have nuclear defect. And this nuclear defect leads to decreased production of RBC. And this is seen in megaloblastic anemia. In short, this is what happens in megaloblastic anemia. So, DNA is composed of adenine, thymine, guanine, and cytosine. Thymine is formed from uracil. Basically, there is a uracil containing molecule which gets converted to thymine containing molecule, and then this thymine containing molecule is utilized for the formation of DNA. However, for the conversion of this uracil containing molecule into thymine containing molecule, two stuffs are required. Number one, folic acid, and number two, vitamin B12. If there is deficiency of any one of them, either folic acid or vitamin B12 or both, uracil will not get converted into thymine. As a result, DNA synthesis will not take place, leading to nuclear defect, leading to decreased production of RBC. This is what happens in megaloblastic anemia. Okay, so finally, let's get into the anemia. Starting off with introduction. So in megaloblastic anemia, there is impaired DNA synthesis due to deficiency of vitamin B12 and folic acid. In order to understand how exactly DNA synthesis is impaired, first we need to understand how exactly vitamin B12 and folic acid are responsible for the formation of DNA, basically their metabolism. Starting off with absorption. So there's a huge process taking place for the absorption of vitamin B12. However, I'm not going to get into the detail. All I want you to know is that for the absorption of vitamin B12, you require intrinsic factor. So vitamin B12, it's bound to intrinsic factor, and then with the help of the intrinsic factor, it gets absorbed in the intestine. Let's say due to some reason, intrinsic factor production does not take place. In that case, vitamin B12 will not get absorbed through your intestine. Who is responsible for the production of intrinsic factor? The parietal cells present in the stomach. If you get rid of the stomach, let's say in case of gastrectomy, you cut the stomach and remove it. In that case, also there won't be parietal cell, there won't be intrinsic factor, and absorption of vitamin B12 will not take place. Or let's say the parietal cells, they become defective. As a result, production of intrinsic factor will not take place. In that case as well, vitamin B12 will not get absorbed, leading to defective production of RBC. Okay, here's the absorption of folic acid, you can see on your own. But let's get into the main part or the main story, and that is the involvement of vitamin B12 and folic acid in the production of DNA, in DNA synthesis. See, as I said earlier, first you have uracil containing molecule that's converted into thymine containing molecule with the help of folic acid and vitamin B12, and then this thymine containing molecule is utilized in the formation of DNA, right? That's exactly what's happening here. You have this uracil containing molecule getting converted into thymine containing molecule, and then this molecule is utilized in the process of DNA, in the formation of DNA. And two things are required: folic acid and vitamin B12. So this molecule right here is called deoxyuridylate monophosphate. This is deoxythymidylate monophosphate, and then finally DNA. For the conversion of DUMP into DTMP, folic acid is required. What happens? So you take in folic acid through diet. So you get your dietary folic acid, which is dihydrofolic acid. See, folic acid is present in two forms. One containing two hydrogen group called dihydrofolic acid, and the other containing four hydrogen group called tetrahydrofolic acid. Your food contains dihydrofolic acid, which is converted to tetrahydrofolic acid. Since there is addition of hydrogen, reduction is taking place, so you require a reductase enzyme. This tetrahydrofolic acid gains a methylene group and gets converted to methylene tetrahydrofolic acid. This methylene tetrahydrofolic acid is responsible for the conversion of UMP into TMP. Once methylene tetrahydrofolic acid converts DUMP into DTMP, it itself gets converted into dihydrofolic acid. This dihydrofolic acid is reutilized as it gets reduced into THF again. So this is where folic acid is used. The question is, where exactly does vitamin B12 come into action? So I said methylene THF is responsible for the conversion of UMP into TMP. But then for the formation of methylene THF from THF, you require vitamin B12. This is where vitamin B12 comes into action. Let's say you take less vitamin B12. As a result, there is less vitamin B12 in your body. Or maybe you take enough vitamin B12, but the absorption of vitamin B12 is impaired due to lack of intrinsic factor. Basically, there is no vitamin B12 in your body. Then what happens? THF will not get converted to methylene THF. As a result, this THF will get trapped at this process right here. It won't be able to move forward from this process. THF will get trapped, folate will get trapped, and this is what we call folate trap. Why does folate trap happen? It happens due to lack of vitamin B12 in the body, leading to what? Leading to decreased DNA or impaired DNA formation. Alright, now etiology. So, be it deficiency of vitamin B12 or be it deficiency of folic acid in your body, there are mainly three reasons behind it. Number one, due to decreased intake. Number two, due to impaired absorption. And number three, due to increased requirement. So, one important thing in intake is that alcoholism leads to folic acid deficiency. Remember, alcoholism leads to folic acid deficiency. Other reasons are simple. Inadequate diet will lead to the deficiency. Veganism will lead to the deficiency. Infants, growing children can be deficient of vitamin B12 and folic acid. Then there's impaired absorption. For vitamin B12, what's required for absorption? Intrinsic factor is required for absorption. So if there is deficiency of intrinsic factor, vitamin B12 will not get absorbed and we will have deficiency of vitamin B12. There are two ways intrinsic factor can go deficient. Number one, if your parietal cells, they become defective, intrinsic factor is not released, and this leads to anemia called pernicious anemia. Pernicious anemia is nothing but a type of megaloblastic anemia occurring due to vitamin B12 deficiency due to deficiency of intrinsic factor. Simple. Second, gastrectomy. If you remove the stomach itself, along with the stomach gets removed the parietal cells. As a result, intrinsic factor will not be produced. There will be no intrinsic factor. Vitamin B12 will not be absorbed. Second is fish tapeworm infestation. If there is fish tapeworm infestation, then there is competition between the tapeworm and your body for the intake of vitamin B12, leading to deficiency in vitamin B12 for your body. Chronic pancreatitis. Chronic pancreatitis because during the absorption of vitamin B12, alkaline medium is required right here for the splitting of a certain complex, which you will know if you read this flowchart itself. And then intestinal diseases. As for folic acid deficiency, simple. If there is malabsorption, folic acid will not be absorbed. Or if there are intestinal diseases, then folic acid absorption will not take place. If there is bacterial growth in the intestine, which can lead to inflammation of the intestine, in that case also absorption of vitamin B12 and folic acid can be impaired. Finally, increased requirement. During pregnancy, during infancy, or during disseminated cancers, the requirement of vitamin B12 and folic acid is greater than the usual requirement. As a result, they might go lacking if not taken in enough amount in your diet. There can be other reasons behind folic acid deficiency. For example, if you take drugs that inhibit the metabolism of folic acid like methotrexate, phenobarbital, or phenytoin, you can see right here. See, if folic acid is deficient or if vitamin B12 is deficient, UMP will not be converted to TMP and DNA production will not take place. Now, folic acid can go deficient due to reduced intake, due to decreased intake, or folic acid may not be absorbed in your intestine due to malabsorption or due to intestinal diseases, or there might be drugs acting that inhibit DHF reductase. As a result, DHF will not get converted into THF and we require THF for this process to take place. Or you can have deficiency of vitamin B12. As a result, THF will not get converted to methylene THF and this process will not take place. UMP will not be converted to TMP. Now, let's look at the pathogenesis. So as I said earlier, in megaloblastic anemia, due to lack of vitamin B12 or due to lack of folic acid, UMP is not converted to TMP. As a result, impaired DNA synthesis takes place. Due to impaired DNA synthesis, DNA maturation lags behind cytoplasm maturation. See, during the process of erythropoiesis, the cells, they go through multiple stages. As they go through multiple stages, nucleus and cytoplasm, they mature side by side. Nucleus matures, cytoplasm matures, nucleus matures, cytoplasm matures, nucleus matures, cytoplasm matures, nucleus matures, cytoplasm matures, nucleus is ejected out, and then you have your RBC. In case of iron deficient anemia, due to deficiency of iron, the cytoplasm maturation was impaired. As a result, cytoplasm was lagging behind. Nucleus went forward, but cytoplasm is still to catch up. So the maturity of cytoplasm was lagging behind the maturity of nucleus. However, in megaloblastic anemia, there is impaired DNA synthesis or defective nucleus. As a result, it is the nucleus that lags behind cytoplasm. Cytoplasm maturation continues while the nucleus is still to mature. As a result, these cells that are formed called normoblast, they become larger in size. Finally, when nucleus is ejected out, the RBC that we get is also larger in size. So what happens? DNA maturation lags behind cytoplasm maturation. Normoblast, these precursor cells are your normoblast. These normoblasts are larger in size than usual due to greater amount of cytoplasm and due to lag in maturation of nucleus. As a result, normoblasts are no longer normoblasts, they are megaloblasts, large. Erythrocytes are no longer erythrocytes, they are macrocytes, they are large. However, hemoglobin synthesis is not affected. In iron deficiency anemia, there was lack of iron. As a result, heme production didn't take place and hemoglobin production was affected. However, in this case, there is no lack of iron, there is no problem with heme formation, and there is no problem with hemoglobin formation. So, hemoglobin synthesis is normal. Hemoglobin synthesis is normal. But then, overall, hemoglobin concentration decreases. The reason being, red cell count decreases. The number of RBC in your blood decreases. As a result, hemoglobin concentration of your blood decreases as well. I repeat, hemoglobin synthesis is not affected, but then hemoglobin concentration decreases due to decrease in red cell count. Finally, in this anemia, what you get are large RBCs, macrocytic RBCs with normal amount of normal hemoglobin concentration inside individual cell or normochromic. You get macrocytic normochromic RBCs. Why macrocytic? Because the mean corpuscular volume of RBC is more than normal, more than 100 femtoliter. Why normochromic? Because the peripheral red is 2/3 and the central pellar is 1/3, or the mean corpuscular hemoglobin concentration, that is the concentration of hemoglobin in one single RBC, is normal. So normochromic. The overall hemoglobin concentration decreases, but then the hemoglobin concentration inside single RBC remains same, so normochromic. But then the RBC count decreases, that is why hemoglobin concentration throughout the body decreases. Okay, clinical features. You have your general features like lethargy, weakness, muscle pain, in old age, angina, heart failure, intermittent claudication, pallor in conjunctiva, nail bed, skin, tongue, and palm. That's general. Along with that, you have specific clinical features due to vitamin B12 deficiency. Why? See, vitamin B12 is required for the formation of neuronal lipids, and neuronal lipids are what forms the myelin sheath of your, they are what form the myelin sheath of your neurons. So if there is lack of neuronal lipids, demyelination takes place, which leads to peripheral neuropathy. You can also see atrophic glossitis, where the tongue is red, smooth, and beefy. Okay. Then lab diagnosis. Same procedure to be followed. You look at three different findings: the blood findings, bone marrow findings, and biochemical findings. In blood finding, you take blood, you make the smear of the blood on the slide, and then observe it under the microscope. You take the sample of the blood and also carry out CBC or complete blood count. These are the results that you will get. Upon observing the smear under the microscope, you will find that the red blood cells, they are larger than the small lymphocytes, so macrocytic. The peripheral red is more than the central pellar, so normochromic. The shapes of the sizes of the cell are different, so anisocytosis. The shapes of the cells are different as well, so poikilocytosis. The cells, they are tear shaped, asucosept, tear shaped, so teardrop shaped. Some of the cells, instead of being round, they are also spherical and large, or oval and large. Sorry, not spherical, oval and large, macroovalocytes. So these are the various types of RBCs that you can find. Then you have your various RBC indices. In RBC indices, the number of red cells, they decrease. Hemoglobin concentration throughout your body decreases. Since the cells are macrocytic, obviously the mean corpuscular volume is greater than normal. The mean corpuscular hemoglobin is greater than normal. Mean corpuscular hemoglobin concentration is normal. See, mean corpuscular hemoglobin concentration is equals to mean corpuscular hemoglobin by mean corpuscular volume. So for the ratio to be normal, if there is increase in MCV, there obviously has to be increase in MCH. Simple maths. Again, look at the part of the video containing RBC indices carefully for you to understand all of these points. So I said that there is defect in DNA and not in cytoplasm. So if there is defect in DNA or defect in nucleus, obviously it's not just gonna be RBCs that are affected, because these precursor cells of RBC, they contain nucleus. Defect in nucleus lead to your megaloblastic anemia. But then nucleus is also present in other cells like your WBCs and platelets. So obviously defects are going to seen in your WBCs and platelets as well. Like what? In platelets, you will find platelets of bizarre forms. And most important of all, the very first manifestation of megaloblastic anemia. Let's say a person suffers from megaloblastic anemia. The very first manifestation that is seen in the blood of that person is hypersegment neutrophil. Neutrophils, they usually have 3-4 lobes, right? But in hypersegment neutrophil, you are going to find more than 3-4 lobes, many lobes of nucleus inside the neutrophil. Then bone marrow finding. Cellularity increases because there is decrease in red cell, so compensatory hyperplasia takes place. Erythropoiesis, nucleus, it lags behind cytoplasm. Marrow iron, it is normal because there is nothing taking place with iron. Biochemical findings, everything related to iron remains normal because iron is not affected. Okay, so in this smears observed under a microscope, you can see hypersegmented neutrophil, which is the very first manifestation of megaloblastic anemia. And then there are three characteristics. These three characteristics, they show defective erythropoiesis is going on. So these are three RBCs with three different characteristics that show that defective erythropoiesis is going on. So here's your Howell-Jolly body, here's your basophilic stippling, and here's your Cabot's ring. Let's zoom in. So first, the very first evidence of megaloblastic anemia is hypersegmented neutrophil. We have evidences of defective erythropoiesis. These are erythrocyte, each of them with typical feature. You can see 8-shaped Cabot ring right here, many dots which are your basophilic stippling, and then Howell-Jolly body. You can see the various types of cells under microscopy right here. So this is your macro-ovalocyte, this is tear-shaped cell, and then this is your macrocyte. You can find cells of different sizes, so anisocytosis, and cells of different shapes, so poikilocytosis. There are various tests that is carried out in order to figure out or test or detect vitamin B12 deficiency and folic acid deficiency. But there is a special test which is responsible for finding, which helps you to find out the cause behind vitamin B12 deficiency. See, how can vitamin B12 deficiency take place? It can occur if there is decreased intake of vitamin B12. It can occur, let's say vitamin B12 we are taking sufficiently, but then there is impaired absorption. Absorption is not taking place properly. Now within absorption, there can be two possible reasons. Number one, if there is no intrinsic factor, or number two, because there is bacterial growth and inflammation in the intestine. So what is the reason behind vitamin B12 deficiency? That is found out with the help of this test called Schilling test. So this is your Schilling test. This is what happens in Schilling test. So again, why is Schilling test performed? It is performed to find out the cause behind vitamin B12 deficiency in your body. What could be the cause? Either decrease in intake of vitamin B12, or lack of intrinsic factor, or bacterial growth in intestine. So there are various stages of this step. By following each of these stages, you test whether there is less intake of vitamin B12 or not. Then in next stage, you test whether vitamin B12 absorption is deficient absorption is taking place due to deficiency of intrinsic factor or not. And in stage 3, you check whether defective absorption of vitamin B12 is taking place due to bacterial growth in intestine or not, one by one. So first, this is what you do. You take 2 different vitamin B12 supplement. 1 vitamin B12 supplement, 2 vitamin B12 supplement. First vitamin B12 supplement is given by intramuscular route, and this is not radioactive. The second vitamin B12 supplement is given by oral route. So you take an oral pill, and this is radioactive. Now in a normal person, this is what happens. So you get vitamin B12 by intramuscular route. Obviously, it reaches the blood much faster as compared to vitamin B12 given by oral route. So vitamin B12 through intramuscular route reaches your blood. From blood, it reaches your tissue and gets stored in the tissue. Once vitamin B12 gets stored in the tissue gets saturated. The tissues, they are full. Their stomach is full. Tissue is full of vitamin B12. They don't require, or they can't take any more vitamin B12. So what happens to the oral radioactive vitamin B12? Obviously, tissue can't take this oral radioactive vitamin B12, so it gets excreted out through your kidney in the form of urine. So you take this urine sample and then test it. You check it. If the radioactive vitamin B12 is found in urine, more than 8 to 10%, more than 8 to 10%, that means there is normal absorption. See, absorption had to be normal so that the oral radioactive vitamin B12 reached the blood. Yes or no? The oral vitamin B12 reached your gut. Now the gut absorbed the oral radioactive vitamin B12 and then it was excreted out of the kidney. If oral radioactive vitamin B12 was not absorbed through your gut, it would not have been excreted out of your kidney. And in that case, less than 8% would be present in the urine. This would signify that there is impaired absorption. So in first case, when there is normal absorption and the person has megaloblastic anemia along with peripheral neuropathy due to vitamin B12 deficiency, you can say that this person is having vitamin B12 deficiency due to less intake. In the second case, you have impaired absorption. Now, impaired absorption can be due to two reasons, either intrinsic factor deficiency or bacterial growth. First, in stage 2, we check for intrinsic factor deficiency. For that, you carry out the same process. You give vitamin B12 by intramuscular route, which is not radioactive. You give vitamin B12 by oral route, which is radioactive. Along with that, you also give oral intrinsic factor. So, if absorption deficiency is there due to intrinsic factor deficiency, what will happen? The intrinsic factor taken by oral route will allow for the absorption of the vitamin B12, right? Vitamin B12 taken by oral route. As a result, upon urinating, vitamin B12, the radioactive vitamin B12 will be present in the urine, 8 to 10% will be present in the urine. This shows that impaired absorption was taking place due to lack of intrinsic factor. But then let's say still, even after taking intrinsic factor, urine contains less than 8% of vitamin B12. That means the malabsorption was not taking place due to lack of intrinsic factor. It is taking place due to some other reason. So we carry out stage 3. In stage 3, intramuscular route vitamin B12 non-radioactive is given, oral route vitamin B12 radioactive is given, and this time you also give antibiotic or anti-inflammatory drug. So antibiotic, anti-inflammatory drug. So if malabsorption is taking place due to bacterial growth, what will happen? Antibiotic, anti-inflammatory drug will act of them, kill them, and temporarily heal the place. As a result, absorption of oral radioactive vitamin B12 will take place. It will get urinated out due to saturation of cell by intramuscular vitamin B12 in the urine. Upon testing, you'll find that 8 to 10%, not 80, 8 to 10% of urine is composed of radioactive vitamin B12. That means impaired absorption was due to bacterial manifestation. This is your Schilling test. By carrying test in stage 1, 2 and 3, you were able to figure out the reason behind vitamin B12 deficiency. From stage 1, you were able to find out the reason being less intake if there is normal absorption. In stage 2, you found out the reason being lack of intrinsic factor if the oral intrinsic factor worked, and in stage 3 we found out that the reason for malabsorption being bacteria if antibiotic and anti-inflammatory they worked. This right here is the summary of everything I just said, the table. You can look at the table.